I'm Ramaswamy Govindan, a medical oncologist at Washington University School of Medicine. We'll go ahead and introduce other panelists here. Dr. Lanuti.
Yes, hi, Michael Lanuti. I'm a thoracic surgeon at the Massachusetts General Hospital in Boston and the director of thoracic oncology for our division.
My name is Cliff Robinson. I'm a radiation oncologist at Washington University in St. Louis.
I'm Sanjeev Bala. I'm the head of cardiothoracic imaging here at WashU in St. Louis.
I'm Dr. Ben Levy. I'm a thoracic medical oncologist from Johns Hopkins School of Medicine.
We have a 62-year-old male with who is a current smoker with a history of stage 2 left upper lobe adenocarcinoma. He declined surgical resection and was treated with definitive chemoradiation, 60 grade 30 fractions with weekly paclitaxel carboplatin, no immunotherapy. Developed recurrence 2 years later in the left upper lobe with clear-cut BDS adenopathy. We're going to be discussing the management of this patient. More specifically, this patient presented with fatigue, shortness of breath, cough, and a performance status of 1, with medical history of chronic obstructive pulmonary disease, not on home oxygen, hypertension, active smoker, 70 pack year history and above, social drinker, and as a family history of lung cancer, mother and father both diagnosed with lung cancer in the 60s. And the CT scan showed a left upper lobe lesion, 2.5 by 2.4 centimeters, and biopsy was consistent with adenocarcinoma, positive for CK7, TTF1, and the FDG PET scan showed an uptake in the left upper lobe with SUV max of 3.9 and no other concerning lesions. And this patient was seen by a surgical oncologist in 2017, as we mentioned before, declined surgery, and then received from June 2017 to August 2017 intensity modulated radiation therapy to a dose of 60 gray in 30 fractions with concurrent weekly standard paclitaxel carboplatin, and had consolidation chemotherapy with paclitaxel carboplatin, but completed only 1 cycle because of neuropathy and arthralgia. And now we are back now with the issue of recurrent disease in the left upper lobe, and we have the CT scan from May 2019. Dr. Bala?
So the CT that we have from May of 2019 shows that there's a 3.2 centimeter long axis mass in the left upper lobe, and it's having some mass effect upon the major fissure. And then we have a follow-up PET CT, which is from May of 2019, which shows that there is this left upper lobe mass with an SUV of 4.3, as well as some mediastinal and left hilar lymphadenopathy, including a 1.1 centimeter left AP window lymph node with a max SUV of 2.4. So in keeping with recurrence.
Thank you, Dr. Bala. So this patient underwent a biopsy of the left upper lobe lesion that confirmed adenocarcinoma and met with the radiation oncologist and medical oncology. And the plan was to treat with concurrent chemoradiation and proton therapy, underwent reirradiation of the left upper lobe and mediastinum to 60 gray equivalent in 30 fractions, again with concurrent weekly paclitaxel carboplatin. And in October of 2019, had a CT reimaging that showed stable left upper lobe disease and mediastinopathy with contralateral lung nodules, treated with chemoimmunotherapy with carboplatin, pemetrexed, and pembrolizumab. So this is somebody who had a surgical resectable disease, stage 2, had a recurrence with a mediastinal nodal disease, treated identically the same way both times, and then had multiple nodules. And the issue is, how do you manage this patient? And this scenario poses some interesting questions in terms of what is the optimal treatment for a patient who refuses surgery, especially node negative disease. Is there a value to do, add chemotherapy or just treat them with radiation therapy? And when is the SBRT appropriate, not SBRT appropriate, the incorporation of systemic therapy with SBRT? And of course, the stage 2 patients who get chemoradiation, should they be treated like the Pacific trial regimen with durvalumab maintenance therapy, like that's given for traditionally stage 3 patients? So these are all a number of questions that we can ask. We'll start off with Dr. Lanuti. So your thoughts on surgical issues in these patients, and how do you approach somebody who is not keen on surgery?
Yeah, I think having a frank discussion with the patient about the outcomes of surgery compared to other modalities is important. That is, it is their choice, and all you can do is give them the data. Surgeons want to be sure that these patients are fit enough, have good cardiopulmonary reserve. If they meet all those criteria for surgery, trying to steer them towards surgery, I don't push hard, because some people really do make their decision. And then you just offer them the next best options, which this patient had. We could argue, like as you said, Dr. Govindan, whether this should have been just radiation alone versus some concomitant type therapy. That's for you guys to comment on. The salvage option, let's say that patient came back 2 years later, this thing's growing. We often try to salvage patients if we can surgically, because the local failure for reirradiation comes with risks. And what's driving, I think, surgeons away in this particular case would be the nodal disease, the AP window, hilum, left paratracheal. On the other hand, one could make an argument that maybe surgery is the modality for local control of the parenchyma. Sweep the nodes if you can, and does that open up opportunities for the adjuvant therapies and reduce the risk of reirradiation?
Thank you. One of the challenges, sometimes patients have a bias that there is a strong feeling among some patients that surgery spreads cancer. And some are genuinely concerned about the pain, the issue of losing some portion of the lung. So you're right. I think we can only recommend them. And but the interesting question really is, if somebody declines surgery, I often struggle with that. What's the appropriate treatment? Radiation alone or radiation with chemotherapy? Let's start Dr. Levy. How strongly do you feel about adding chemotherapy to radiation in a scenario like this, node-negative stage 2 disease, otherwise operable?
Yeah, I think this is where the really underscores and highlights the importance of the partnership with the medical oncologist and the radiation oncologist. I do have these discussions with my radiation oncologist all the time. If it's going to be a short 5 fractions of SBRT, then I generally do not consider giving chemotherapy concurrently or consolidatively. If it's going to be a more prolonged course, as it looks like in this case, I tend to offer it for fit patients. We don't have a lot of great data on stage 2. Most of the data we have for concurrent chemoradiation is in the unresectable or resectable stage 3 setting. We need to remember, stage 2 is still an unforgiving disease with a high risk of recurrence. So I think the strategy is nuanced in my case. I will talk to the radiation oncologist. I have offered it in the past if they're going to give 30 fractions. If a patient is willing to come in based on, not a lot of data, I do. I offer weekly carboplatin paclitaxel, and I'll just put my nickel down as well and say that I would even consider, I have had patients, again, I said that I'm a purist when it comes to specific on one point, but here I am going against myself saying that I would offer immunotherapy to a stage 2 patients, which weren't included in the Pacific study. These are patients that still, again, have a high rate of relapse. So I would consider offering weekly paclitaxel carboplatin with radiation. I would even have a discussion for immunotherapy. It's a discussion, even though the Pacific trial did not include stage 2 patients.
Yeah. That's true. And I think with the node-positive disease, it's a different story. We have compelling data with adjuvant chemotherapy regimens that, even though modestly, it improves overall survival. Node-positive patients, node-negative patients, I have some ambivalent feelings. But a lot of discussions in the management of patients who are surgically resectable, but either not operable, not willing to go through the operation, or inoperable stage 2 for some medical reason. They rely on radiation for most part. That's where all our questions come from. So we medical oncologists get easily confused, Dr. Robinson, about photon, proton. When is proton better than photon therapy? Is there truly data to support proton in a setting like this, or is it just a new modality that's attracting attention, and also when the SBRT is safe, particularly the central lesions. So can you please enlighten us?
Absolutely. There's a number of nuanced discussions there. I think the first thing I want to echo is what Dr. Lanuti said, which is that it is really important that patients recognize that in the absence of randomized data, that surgery is the standard of care for medically operable early stage lung cancer and has a long-standing best outcomes that we have to date. The notion of a patient who is medically operable and refusing, I think, is often the gray zone. It is very rarely somebody who is a marathon runner who just flat out refuses surgery. It's often kind of a scenario where they maybe have some internal sense of their concerns of their medical health. But I think that gray zone is ripe for a whole other discussion. With that being said, if a patient has flat out said they are not doing surgery, or we've determined that they're not a good operative candidate, I'd like to emphasize that in the absence of nodal disease or a very large tumor, or even perhaps a tumor that's highly invasive into the central structures, SBRT is the current de facto standard of care for these patients. So it is unusual to consider a course of lower dose fractionated radiation with chemo and subjecting those patients to a much higher toxicity profile for a isolated lesion in the lung. There's typically extenuating circumstances where you might consider that, as I mentioned, if it's encroaching into and including the hilum, or perhaps what we call ultracentral, meaning touching the esophagus or coming into the mediastinal structures. But at least for the lesion that we were shown on the CT scan, that would be one we would typically consider treating with SBRT alone. Now, with that being said, to the point of, I'll just quickly address technology, protons versus photons. It's a bit of a straw man issue. There's a lot of data one way or the other. The main potential theoretical advantage to protons is that there's less low-dose scatter radiation. That's really the main benefit. It's questionable whether that has any real significance for these patients with earlier stage disease. As you have more advanced disease with nodal involvement and more potential for treating the uninvolved heart and lungs, there is theoretical advantages to those lower doses. That remains to be seen, and that's being actively tested in a randomized trial. The last thing I want to comment on is the notion of systemic therapy combination. The biggest confounder for these patients getting SBRT is that they tend to be unhealthy and inoperable, and therefore also the ones that we might be concerned giving cytotoxic chemotherapy. I think even you would agree that for earlier stage disease that it's somewhat softer in terms of the notion of the potential benefit for platinum-based chemo, even in the adjuvant setting. With that being said, there's a lot of interest in adjuvant immunotherapy based on the very exciting results from PACIFIC. There are now 3 ongoing randomized trials comparing SBRT plus or minus immunotherapy, particularly for larger tumors like this one. So this patient would have been an excellent candidate for either of the 3 main open randomized trials. And I think that's really where we're hanging our hat, is this notion of combining SBRT and immunotherapy in the future.
Terrific, Dr. Robinson. Thank you so much. One of the challenges when you follow these patients, we often face is this radiation-related scar tissue and what is really viable or growing tumor. In fact, the 3 of us had a patient this week, and in fact, I called Dr. Bala to discuss his management yesterday, and Dr. Robinson the day before, real-life situation like that. Dr. Bala, do you want to comment on the challenges in interpreting the CT scans when the lesions seem to be growing, but it may still be a radiation effect?
Yeah, I will say that radiation is a real perplexing problem on CT, because you can sometimes see changes in radiation up to 2 years after the radiation treatment in the lungs. And sometimes they can look very mass-like. And then I think confounding that is the phenomenon that you can have increased uptake of FDG on a PET scan, and so it can start to simulate a mass. We think that there may be a role for MRI, getting to what Dr. Lanuti has described on some of the other cases in terms of using diffusion imaging, and there's a lot of research right now trying to see if that's possible. But for the most part, what we find to be very, very helpful in the current arena is to be using CT and to try to correlate with the radiation fields. And that's where something Dr. Robinson and I have been working with and trying to look at the radiation planning on the CT that was used by the radiation oncologist and correlating with the diagnostic CT to help. But it can be a real problem trying to figure out the difference between recurrence and radiation treatment changes.
So that's an interesting point. Do you think there will be a time when a radiation oncologist can upload a particular set of images that would be relevant for CT radiologists who read the films on a busy day? You read 100 CT scans and you don't have time to review this extensively. Are you referring to that kind of a setup where there will be a standard radiation therapy field that would be helpful for you and your colleagues to read or interpret?
I believe, personally, I think that should become the standard of care, hopefully not in the too far distant future, that if we were able to have an idea of the radiation field, I think that with AI, we have the potential to overlay a radiation field with our CT diagnostic findings to try to get a sense of what's within that field, what's on the perimeter of the field, and what's clearly remote from the field. And I think that will help us with our diagnostic capacity. So keeping our fingers crossed, but I hope that that's the trend that's going to be in the future. Cliff?
I would agree with that. And I would actually say right now the bar is quite low because at a minimum, just knowing where we treated and even which lung we treated would be helpful. I often get blamed for radiation pneumonitis when I treated the contralateral lung or perhaps didn't treat the lung at all. So I think that we have a lot of room for improvement, and what a wonderful opportunity for continued multidisciplinary work.
Yeah, that's great. I think this is a great place for artificial intelligence to be merging into the real intelligence here of human intelligence, like Dr. Bala's. But I also want to quickly underscore the point that there is a common misconception that the FDG PET scan after 9 weeks after radiation is going to tell everything. This is not lymphoma. We continue to see persistently positive FDG uptake in some of these patients who never recur. I've seen that anecdotally. Any comments from you, Dr. Bala, and then Dr. Robinson?
Yeah, I would agree with you that we've seen that the FDG is oftentimes misleading, that sometimes you'll see that there's uptake in an area of radiation. And we've had other instances where there's been a necrotic lymph node that hasn't taken up much at all, that's a distant metastasis. And so I think that the FDG PET, like any other imaging, has to be viewed in the context of where the radiation field was and the time course of changes. I think that's really important.
Yeah, I would absolutely agree with that. One of the most common scenarios we see with a false positive is a slow-growing, low-grade adenocarcinoma that we give SBRT to, and then the PET uptake post-treatment, if somebody were to order that scan, is much higher than the baseline, which would seem relatively inconceivable for recurrence. So with that being said, I also think the time course is critical. Early on, PET has diminishing values. Later, that value, I think, increases, particularly when you see that there's so-called pushing borders or tumor going outside of that. And, I would also say that within that context, we probably also can underappreciate failures that are occurring underneath our noses. And there may very well be situations where you have fibrosis and you say everything looks fine, but in fact, there may be early failure. So anything we can do to improve that with imaging and otherwise perhaps circulating tumor DNA and other methods to combine with that, I think we're all looking forward to being able to diagnose that earlier.
Right. That's a topic for an entire hour, circulating tumor DNA. And in general, the false negative rates with current assays are very high with predominant intrathoracic disease. So, but hopefully the technology and the techniques that evolve will address that at a later point.